applied to the adaptive shortened scar tissues. So that also will cause some pain. So these are the mechanical deformation. Chemical pain, we'll see that. So which is not been related to the physiotherapy treatment. I mean the mechanical therapy. The chemical cause, it's like inflammation or the infections. If there is an inflammatory signs present, if there is a chemical substances, so which can able to stimulate the free nerve endings of the nociceptors. So the inflammatory substances, so that can cause a chemical pain. So there is no change of the pain. The chemical pain means there is no change of the pain. Okay, any positions, even if there is a movement or there is no movement, the pain will be the constant. So there is a constant pain. There is a continuous type of pain. So that is not altering the pain because of the movement or the position. And definitely the mechanical pain that will be relieved by the chemical therapy. Chemical pain, this will be relieved by the chemical therapy like drugs, anti-inflammatory drugs. So traumatic pain. So the traumatic pain is followed by the trauma, injury, and this is the damaging the soft tissue. So at the time of the damaging the tissues, and this is mechanical deformation. There is a slicing the tissues. You are taking the knife or blade and cut the skin. So at the time of the tissue, when there is a tissue damaging, so there is a mechanical pain. Followed by that, there is a chemical origin of the pain. So there is a constant pain. Once the tissue is damaged, then it switch on to the next stage of the inflammation. So there is a constant pain will occur. So the mechanical therapy. So immediately after the injury, once you've been put in the strap or the positioning or bandaging something, so which can able to protect the damaged tissues. Okay, so that will reduce the severity of the mechanical pain. And the chemical therapy that requires the chemical pain. And now we will see the pain history. So the pain history, that the name, age, sex, occupations. Okay, so this is a common one. And where is the pain being felt, and how long the pain is present, and how did the pain commence? You can ask the patient. So let the patient explain in his own words. Is the pain constant or the intermittent? What makes the pain worse or the better? And have there been any previous episode of the low back pain? That also you can ask the patient. And further any clarification like whether the patient have pain during the cough or the sneeze. Okay, so that shows there is a disturbance of the intervertebral disc. And is there any sleep disturbances? Is there any sleep disturbances followed by the pain? And pain on arising the early morning. On any steroid the patient is taken for the past and present. Any reason weight loss, major surgery, and any saddle anesthesia, bladder control, the sacral, the nerve compressed. So that also causes the saddle anesthesia, the bladder control. And next one, the pain assessment. This pain assessment detailedly is being taught by my teacher, Professor A.G. Dandapani sir. Very, very detailedly he has told about the pain assessment. So what my teacher has been taught in that, I think I could be able to deliver 1%, that will be this very fine. So the onset of the pain, whether it is a sudden or it is a gradual onset. Whether the onset of the pain is a sudden or gradual. Sudden means if there is any fall, the patient develops the pain because of the fall. There is a sudden onset. If there is a gradual, without any fall or accidents, without any trauma, if the pain is started gradually, okay, that is what onset. So we can ask the patient whether the onset of the pain. Then site of the pain, it's a location, the anatomical location of the pain, and whether the site is the left side or the right side or is in the center, where is which side is there. Type of the pain that described with the patient words. Patient let the patient explain about the type of the pain. So sometimes the patient may explain in his own mother tongue or his own local language. He'll explain about that. Okay. So commonly that we have to differentiate how the patient is being explained, and we have to try to understand the way what the patient is expressed. Same way the physiotherapists also try to understand the type of the pain. And the duration of the pain, or it's called as the age of the pain. Okay, how long the pain is experienced by the patient. And there is a character of the pain, it's a continuous pain or the intermittent pain. Already we have seen continuous pain, it's a chemical origin or it's inflammation. If there is intermittent type of pain, it is a mechanical origin pain. Aggravating factors, what are the factors? What are the factors can be able to aggravate the pain? Sometimes even the rest also will aggravate the pain. Okay, so always we should not think about the rest will relieve the pain, not like so. So sometimes the rest also will aggravate the pain in case of inflammation. And if it is a relieving factors, so sometimes the movements also will relieve. Sometimes movements will relieve the pain. When the patient is stand, the patient may get a pain. When he start walk, the pain may be reduced. So we have to ask the patient what are the factors, what are the position, what are the movements, okay, which will be relieve the pain. And there is a 24 hours pattern. We have to ask the patient very clearly the 24 hours. Okay, start from night, midnight, early morning, and noon time, afternoon, evening, then night, again the midnight. So in the 24 hours, in the time, which time the patient get more pain. Okay, so definitely the particular time factor which can able to relate to the pain also. The severity of the pain, it is a vast visual analog scale. So we have to draw a line. It's a plain line. That's a 10 centimeter line. That line is a 10 centimeter. Only physiotherapist should know, the patient should know that. We have to explain that one end is zero, another end is this end is no pain, another end is a severe and tolerable pain. So that's what we have to explain to the patient. So mark this area where you feel more pain, that you mark it. So the patient will feel, try to quantify the pain. Okay, if the patient try to quantify his pain is around 80%, he will try to come up severe pain. From that little bit of forward will come and he will mark it there. So let the patient quantify how much pain he has. Accordingly, he can able to mark the region. Okay, the line. So this goes about the visual analog scale. Irritability of the patient, irritability of the pain. The irritability of the pain, this will be described mild, moderate, and the severe. So how it can be quantified? If the patient get pain relief at the rest, you can ask the patient how long that it takes to relieve the pain completely. So if the patient is within 3 seconds, the pain reduces. Okay, completely the pain goes. Okay, when I was standing and getting pain, when I sit, there is no pain. So ask the patient whether immediately sit, the pain is relieved immediately. So patient say it's a mild, it takes few minutes, it's a moderate, it will take around 15 minutes, 20 minutes after sitting. So it's a severe irritability. So it depends on the nature of the pain will be described, whether it's a mechanical pain or the chemical pain. So we'll see the articular neurology part. This articular neurology, even the last class also we have been explained these all the things. So I'll be a little bit of refresh about that articular neurology. So there is a 4 type of neurology: type 1, 2, 3, and 4. And type 1 is a thinly encapsulated, okay, globular corpuscles. This located on the fibrous capsules of the joints in the superficial layers of the capsules. And the parent nerve fibers is small myelinated fibers. And what's the behaviors of the type 1 is? The behaviors of the type 1 is there's a static and dynamic mechanoreceptors, and this is a low threshold and slowly adapting fibers. Type 2 is a thickly encapsulated. Type 2 is a thickly encapsulated conical corpuscles, and this located on the fibrous capsules of the joints in deeper subsynovial layers and in particular fat pads. And this is a medium myelinated nerve fiber, and this is dynamic mechanoreceptor like low threshold, and this is rapidly adapting fibers. Type 2. Type 3 is a thinly encapsulated fusiform corpuscles. This located on the surface of the joint ligaments and the collateral and the intrinsic. And this is large myelinated fibers, and this is dynamic mechanoreceptors, high threshold and slowly adapting fibers. And type 4 is a tridimensional plexus of the unmyelinated fiber, nerve fiber. This is a type A, and this is a 4B. It's a free unmyelinated nerve endings. And locations of 4A located on the fibrous capsules of the joint, articular fat pads, and adventitial sheets of the articular blood vessels. And 4B, it is located on the joint ligaments, collateral and intrinsics. And the parent nerve fibers of the type 4, it's a very small myelinated fibers, and located on this behavior, 4A, it is a nociceptive mechanoreceptor. It's a very high threshold and it is non-adapting. And 4B, it is a chemosensitive. When the patient take medicines, Okay, that will be definitely it is work on the 4B, and because of that receptor has been keeping quiet, the patient will feel that pain is reducing. So this is chemosensitive receptors. This to absorb the tissues, metabolic nonsensitive receptors. So the 4B is receptors only will be respond to the chemical substances. What are the central effects of the articular mechanoreceptors? There is a reflexogenic effects and perceptual effects, and there is a pain suppressants. So reflexogenic effects, the articular mechanoreceptors exert the reciprocal, the coordinator reflexogenic influence on muscle tone. When the therapy is given, mobilization given that, and definitely that influence the muscle tone of the joints around the joint, and this manipulation not only on the near to the muscles tone, and even the far muscle, remote muscles also, the reflexogenic effects will be take place. And the manipulation gives rise that give rise to the reflex changes of the muscle tone, entire muscle tone in and around the joint, and even the remote muscles also. So that's what the reflexogenic effects, followed by that the pain reduction is there. And there is a perceptual effects, like this is type 1 mechanoreceptor. This contributes the perceptual experience of sensation and kinesthesia. So the patient, when patient stand or when he moves, he knows that without knowingly, without seeing that joint, also he can come to know that whether the joint is in the flexion or extension, whether he is standing erect or is in the bend position, everything he can able to feel that. So that's because of the type 1, the mechanoreceptor, that keeps informed to the brain about the position of the or the movement sensation of the joints. So the destructions of the articular mechanoreceptors that manifest this impairment of the postural and kinesthetic stability. So if there is a type 1 mechanoreceptor has been damaged, definitely patient will feel the position sense, that's impairment of the position sense or the movement sense. So the pain suppressions, the mechanoreceptors, definitely the mechanoreceptor stimulation by the therapy or manipulation, that will produce a presynaptic inhibitions of the nociceptive afferent activity in basal ganglion nuclear neurons. Now we'll see about what is the relation between the pain and the range of motions. The movements, if there is a movement, if the movements need to be get full range of motion, so definitely there should not be any restriction by the pain. If there is a pain presence, definitely the movements will be reduced. So the pain and the range of motion will be the interlinked. So there is a physiological movements and accessory movements. What is physiological movements? Flexion, extension, abduction, adduction, these are all the movements. It's called as a physiological movements. And what are the accessory movements? Gliding, sliding, spinning, rolling. So the movements which take place between the articular surface, that's accessory movements. And that biomechanism is called as the orthokinematic movements, and the physiological movements called as the osteokinematic movements. So the osteokinematic movements, without the orthokinematic movements, there will not be any osteokinematic movements. So when there is an abduction of the shoulder joint, if take place, so the humerus moves on the abductions, it moves laterally and upwards. So abduction is taking place. So what happening at the articular surface of the shoulder joint, the head of the humerus, which is a convex surface, which will glide downwards over the concavity surface of the glenoid fossa. So the glenoid fossa, the head of the humerus will be glide downwards, then automatically it can produce an abduction movements of the humerus. So without the accessory movements, there will not be any physiological movements. So what is the kind of end range? So what do you mean end range? The end range, the movements, once the movement starts and movement will be end there. How many end ranges are there? There are two end range. One is a physiological end range, which can able to limit by the tissue stretch or the tissue approximation. When you bend the elbow, when there is a biceps muscle bulk and the muscle bulk of the flexus group, so which can able to approximate each other, so that limit the range of motion, that stop the range of motion. So that is called as a physiological end field. Anatomical end field, it is end field or the end range, the anatomical end range. So the bone and bone will be contact each other. When there is a bone of, the radius, say for example, the biceps, elbow flexion you take, there is a radius and ulna will flex forward, it moves forward towards the humerus. When both the radius and ulna will contact with the humerus, the movements end there. So there will not be any further more movements will be available because bone and bone contact each other. So when the bone and bone contact each other, the movement absolutely end. That is called as anatomical end range of motion. So elbow extension is an example of the anatomical end range. When you do the elbow extension, the olecranon process will go inside the olecranon fossa, and that is lock. So once the lock, the bone and bone contact each other, so the elbow extension end, there will not be any further range of motion available. So now we will see about what is a concave convex rule. We are going to see that integrated manual therapy. So it is being described as a Concave Rule. So what is a concave convex rule? Concave convex rule, when there is a joint, the movements are there. So one convex surface of the surface of the joint surface, which will be outlined with a concave surface. So when there is a convex surface of the segment, the extremity is moving one direction. So there is a gliding will be in the opposite direction. So say same thing I told in the examples of the abduction of the humerus. When there is a abduction is taking place. So the osteokinematically there is abduction is there. Orthokinematically there is a inferior. So inferior gliding. So the head of the humerus will glide downward. So which will be in the opposite direction. It can able to improve the upward direction. So same thing, if there is a concave surface, move over the convex surface. So both the gliding and the osteokinematic movements both will be the same direction. Say for example in the knee joint, when the convex surface is the contents of the femur, and concave surface is the contents of the tibia. So when there is during the knee flexion, so the tibia is moved over the femur. So the concavity is moving backward. So there is the tibia moves backward. Same time there is a gliding of the tibial condyle over the femoral condyle that takes place. That is also in the posterior direction. So both are in the same direction. So this is what a concave convex rule. This has been described by Colton Bone. Now we'll see about the manual therapy concept. What are manual therapy concepts? So Colton Bone is forefather of all the manual therapy concepts. So he described about so many other techniques. We'll see about that each and every concepts about that, but not in detail about that because each concept has been very large, and even the assessment technique, treatment approaches, everything has been very vast. So we'll be see about integrated. What is that? Each and every concept the author has been told. Maitland, McKenzie, Syriacs, Mullikans, and the Butler. So now first we'll see about the concept is called Maitland concepts. Hope it has been audible by everyone. Yes. Now we'll start the Maitland concept. So the Maitland concept, it has been told, never think about pain without think about the range. Never think about the range without think about the pain. So this is what the main Maitland concept told. So if you want to improve the range of motion, first of all, you have to think about the pain reduction. Without think about pain reduction, you cannot improve the pain. You cannot able to improve the range. So without think about the pain, you can't improve the range. If you want to think about the pain reduction, definitely you have to think about the range of motion. So the range of motion has to be increased. Followed by that, the pain reduction automatically will happen. So this is what the Maitland tool. So you can see that one straight line. So this is what the movement starts. So movement start from there. Okay, so this is the position, the movement starting from here, and the movement end there. So when the movement end here, there is a two end range. You can see there is a first one. It is a physiological end range of motion. Last one, it is a anatomical end range of motion. Okay, so this is what the grades of mobilization. You can see the grade 1. This is a small amplitude rhythmic oscillation at the beginning of the range. And next one is a grade 2. This is a large amplitude rhythmical oscillation where the grade 1 end. And grade 3, it is a large amplitude rhythmical oscillation starts where the grade 2 end. So the grade 2 and 3, this will occupy the middle range of motion. And grade 4, the last one, so the pictures and the explanation is a little bit of wrong. So the grade 4, it is a at the end of the range of motion, which will come and touch the range of motion, end range of motion. So that's what the grade 4. And grade 5, which will be override the physiological range of motion, physiological end range. So first one is a physiological end range. So on that, you can see there is a one more horizontal, small horizontal line which has been crossing over there. So that is a grade 5. So grade 5 is nothing but it is a sudden thrust. So sudden thrust movement will be given. It is not a rhythmical oscillation or nothing at all. So there's a sudden thrust will be given, which will be tried to push the barrier away from that. So if the pain, if it is sitting on the grade 1 range of motion, grade 1 area range of motion of that. So once you select the grade 1 mobilization, so that pain will be shifted from grade 1 area to grade 2. Then again you select the grade 2 mobilization, it will move on to the grade 3 area. Again you select the grade 3 mobilization, it will go to the grade 4 area. Once you select the grade 4, small amplitude, then you come and sit on the boundary line of the physiological end range. So absolutely that full range is become pain free, and now the pain can sit on the boundary line of the physiological end range. Now you have to select grade 5 range of motion, that is a end range. So at the end range, you have to give a thrust, sudden thrust movement you have to give, and try to cross the physiological range. So once you try to cross the physiological range, so which will push the pain away from the physiological range, So completely the full range of motion, the full physiological range of motion will become free, and even at the end range, the boundary line of the physiological end range, they are also pain free. Okay, so if the pain is sit on the physiological end range, what the patient will say, sir, there's no pain is here, but at the last end range, when I'm been completing the range, and that point will I'm getting pain, sir. It means the pain is sitting on the end range of the boundary line of the physiological end range. So that time you have to select the grade 5 mobilization, and you have to try to push the pain outside from the boundary line of the physiological end range. So this is what the mainline, the concept, and this is called as a movement diagram. So what I have been shown you, this is the movement diagram of the mainline concept. This is the main core concept of the mainline. Now we'll see about what is the Mulligan concept. So Mulligan told so many other variations from the mainline concept. So one variation is the mobilization. Why don't we give mobilization at the weight in the weight bearing position? But Maitland told if you want to be given mobilization, you have to make the joint comfortable, particularly in the non-weight bearing position. Maitland is not been described about the weight bearing position mobilization, but the Mulligan describe about the mobilization can be given at the weight bearing position also. And Mulligan has been not told about mobilization cannot be given in the non-weight bearing position. So it can be given in the non-weight bearing position also, but the mobilization given in the weight bearing position, it have something different kind of effects. So this is what the Mulligan told. And there is a nag and snag techniques has been described by the Mulligan. So what is nag? It is a natural apophyseal gliding. So apophyseal joint is nothing but is a facet joints. Zygapophyseal joint. So facet joint, it is located on the vertebral columns. So the facet joint is called as a apophyseal joint. So the natural apophyseal gliding. When there is a normal natural apophyseal gliding movements are taking place on all the vertebra, complete vertebral column. So movements of the vertebral column, the cervical spine, thoracic, lumbar spine will become smooth, and there is movements are complete. There is no pain, there is no restriction. Range of motion will be complete. But if the apophyseal gliding is not take place properly, so the patient will get pain and movement restriction. So the snag, it is called as a sustained natural apophyseal gliding. So sustained, what do you mean sustained? So there is the mobilization will be given, and the force should be maintained. As long as the force maintained, the movements, the mobilization, the joint articular surface have been moved each other, and once the force has been applied and it has been sustained for a little time, maintained, and the articular surface also has been moved, and the mobilization will be maintained. So that's what the sustained. So for that sustainedly, so Mulligan told to use the belt. There is a separately Mulligan belt is been available. So Mulligan belt. So that with the belt will be there. Otherwise, he told in a program, I think, and all. he'll advise the patient to use a towel or the small kind of dupatta, okay, small the kind of not a rope like this. So it's like the flat like a belt type of things, okay. So that kind of things and all which will be used for the sustained mobilization. So the direction of the mobilizations, this is also very important. Mulligan told there is a two particular way of the directions. One is a caudal mobilization, another is a subfluid mobilization. Caudal, one is in the downward direction, another is in the upward direction. Okay, but this kind of different direction of the mobilization is not been described by this Maitland. Maitland told this is mobilization, but the direction of the mobilization not told. This is by the grades of mobilization we described by the Maitland. But Mulligan variation is the differentiation that there is a direction, is a caudal mobilization and subfluid mobilization. Mobilization parallel to each other. Yes, when you give the mobilization, the articular surfaces should be properly, it should be parallel each other. So that is called medial and lateral glide. So Mulligan's medial and lateral glides also is there. In case of the patient who has the tennis elbow or golfer's elbow, there is a Mulligan glides will be given at the elbow, and the humerus will be held by the one hand and the radius will be held another hand. And the holding the hands supposed to be the parallel each other, and the forces what you've been applying to the both the segments, that should be exactly parallel each other. The forces will be parallel, and the mobilization, the movements, the mobilization glide also will be take place in the parallelly, and there is a very good different effects will be take place. So that's what medial glide. You can give the force medial glide, medial side, but the forces supposed to be the parallel each other. Both forces should be parallel each other. So the mobilization, the medial mobilization will be. So this is very good the mobilization technique for the tennis elbow and the whole patient. Another one more thing is mobilization with movement. So mobilization with the movement. So this is also the important the technique in Mulligan concepts. So when you give mobilization, but other authors is not told about when you give mobilization, you can ask the patient to move. No, but Mulligan told you mobilize the bone, the segment, and hold the mobilization, ask the patient to move. Say for example, when there is a cervical spine, the mobilization force will rate on the vertebra, the cervical spine, and we'll ask the patient to move the cervical spine, the extension and the flexion. Okay, and once the patient return back to the neutral position, again the force will be relieved. So apply the force, we'll ask the patient to move the head in the extension, again bring back to the neutral position. Once the patient comes back to the mobilization force will be relieved. So the force is applied and there is a mobilization taking place. Now the patient also will do the active movements maximum. Okay, how much ever patient can able to do the maximum, the movement, the patient can able to do that. So once the patient return back to the neutral position, the mobilization force will be relieved. So this is what the mobilization with movement. The next concept we'll see about the kind of McKenzie concepts. So the McKenzie concept, before going to understand the McKenzie concept of things, we should be thoroughly know about the curvature of the spine. And understanding the curvature of the spine is very important. There is a primary curvature and secondary curvature. Primary curvature is kyphotic postures. Okay, so this is primary curvature. Secondary curvature is a lordotic curvature. So when the baby is a small baby go to the prone line at month of third or fourth month, so the baby will try to lift the head up because the nose hit on the ground. So they will try to lift the head up. So that time the lordotic curvature of the cervical spine form. So after 8 months, 9 to 10 months, then the baby try to do the push-ups and try to lift the body up. So that time the lordotic curvature of the lumbar spine develop. So when completely the baby come up, stand up in the upright posture, so the curvature is already formed. The curvature, because of the curvature, the baby can able to stand up. If the curvature is not developed earlier, when the baby is in the fetus, so completely the full spine is in the kyphotic posture. Completely it is in the kyphotic posture. So with the kyphotic posture, if it is there, whether the human can able to come up and stand erect, upright posture, no, it is not possible. So the curvature is being developed. So the developed curvature, the secondary curvature, the primary curvature has to be maintained the proper way. So when the curvature has been abolishing, the lordotic curvature or the kyphotic curvature has been increased or decreased, the spine, so definitely the patient will develop the spinal problem. So McKenzie deal with all the spine problems. There is a three syndromes McKenzie described. One is a postural syndrome, second one is a dysfunction syndrome, and third one is a derangement syndrome. Postural syndrome, if the bad posture, because the pain comes because of bad posture. Even when you sit around 10 to 15 minutes in the bad posture, lean forward and things, after 15 minutes you try to get up, so you definitely will get a pain. So that's because of the poor posture. So the bad posture, that gives a stress to your tissue, and the tissue become deformed. Okay, it is not completely deformed, it's about to deform, so the pain has come. So when you come back, try to come back, so you get a pain. So this is what the posture. Just you correct the posture, automatically the pain relieves. This is what the posture syndrome. Dysfunction syndrome, if the posture continues for a longer period, that makes the tissue do some kind of adaptive changes. So the tissues, there is a kind of changes will take place on the tissues. Adaptive shortening of the tissues. Commonly, this will take adaptive shortening of the tissue. So the tissues become adaptive shortening, and afterward, when you try to bring back the neutral position, the tissue will not allow that joint to move. So this is what the dysfunction syndrome. So McKenzie described what there is a flexion dysfunction syndrome, extension dysfunction syndrome, and side gliding dysfunction syndrome. Flexion dysfunction syndrome, the patient is not able to do completely flexion. So when the patient tried to bend forward, but the spine is very stiff, so there is a flexion is not possible. And extension dysfunction syndrome, the patient tried to do the extension, but it is not happening because the spine, the lumbar spine is not a proper curvature. It is not. So the patient is leaned forward continuously. So when the patient tried to do move backward, there is extension. That extension will not be possible. That side gliding dysfunction, the patient can able to move the sideways, the gliding movements, sideways gliding movements of the vertebra. So the dysfunction syndrome, it is because of the adaptive shortening of the soft tissues around the joint. Derangement syndrome, the spine is in arranged proper way, it's alignment of the spine. Vertebra, above one vertebra, one disc, then again one vertebra, then disc, vertebra, disc, vertebra, disc. So this is what the spine is completely aligned. So if the disc is trying to come out, or the vertebra it has been moved out from the place, so this is called as a derangement syndrome. So this is what the categories of the soft tissue problem and the pain and the dysfunction. It is categorized the McKenzie, postural syndrome, dysfunction, and derangement syndrome. So there are test movements usually the McKenzie has been told. The flexion lying, flexion in standing, and extension in standing, extension in lying, side gliding in standing. So there are 5 test movements is described by the McKenzie. So when the patient is in the standing position, the standing, so we'll ask the patient to lean forward and try to touch the ground. So how much the range, the movements are there, the pain where is coming will be examined. Then flexion in lying, the patient is in the lying posture, supine lying. He'll try to bring the hip and knee flexion and try to bring it towards the chest. So it's what flexion in lying. Extension in standing, in the standing position, keep the hand on the gluteal regions and support will be given, and patient will try to move the spine backward. And extension in lying, prone lying posture, patient will give the hand on the bed, okay, and he'll give pressures, and the patient will try to lift the head, shoulder, chest upward. So this is what extension in lying. Side gliding in standing. So in the standing posture, so we can, it's not a side flexion, it is a side gliding. So the shoulder, chest will be try to push parallelly to the pelvis. So it's what a side gliding in standing. And mobilization is been emphasized. The mobilization should be done by the patient support, and only the therapist can able to assist the movement. If sometime if it's required, if there is a movement is not coming there, so the therapist will give the force on the hand, and he will try to apply the force, and it's just like a manipulation force. The manipulation force, sometimes the mobilization also will be required to done by the physiotherapist. Almost 80% of the movements are done by the patient itself. This is what McKenzie concept. Celiac concept, the movement restriction by the soft tissue. Okay, not only the articular surfaces, even there is a soft tissue surrounding the joint that also can reduce the movement. So the restriction of the movement can be offered by the soft tissue surrounding the joints. So if there is any inflammation, Syriac is an orthopedic surgeon, so he used to give the patient who come with this periarthritic shoulder, if there is inflammation, if it is there, so he'll be given a kind of steroid injection in the joint. And followed by that, he as the physiotherapist to go for the soft tissue friction massage. So he is the one, Syriac is the one who has been explained about the capsular pattern and the non-capsular pattern. So capsular pattern, the capsule can restrict the movement. Okay, we used to study about in this the syllabus of the physiotherapy syllabus. So the capsular pattern or non-capsular pattern. So if the capsular pattern, it is like flexion, abduction, and external rotation. So flexion, abduction, and external rotation, capsule will be stretched maximum. So this is what the capsular pattern. Non-capsular pattern is the adduction with internal rotations. So this is what the non-capsular pattern. So the capsule, if it is being restricted, if the capsule is being tight, so it can able to restrict the movement. So what are the ways the capsule can able to shrink and it can able to restrict the movement? So this is what the capsular pattern. So non-capsular pattern, it is not in the capsule restriction. There is some other things other than the capsule, any other soft tissues or the intra-articular problems, if it is there. So that's a non-capsular pattern. So the concept of the Syriac here is, for the physiotherapy profession, is the transverse friction massage. So if there is inflammation, infection, definitely we can't apply for any manual therapy concepts. Mechanical therapy is not been effective on this inflammation and infection. So that time the chemical therapy only will be advised. So once the inflammation is reduced, Syriac asks the physios to go for the transverse friction massage, because the elasticity and the softness of the soft tissue surrounding the joints is very important. If the elasticity is not improved of the surround the joint, definitely movements cannot able to improve that. So this is what the transverse friction massage that will be emphasized by the Syriac around the shoulder, around the particular joints will be given, and the friction massage, transverse friction massage, that will increase the temperature, local temperature of the capsules and the soft tissues, and definitely that also will improve the elasticity of the soft tissue. Yes. Now we'll come to the old method. This one, Colton Bones concepts. The concave convex rule. The concave convex rule is important for pillar. This is important pillar of the manual therapy concept. All the manual therapy concept is concave convex rule. This is being told by the Colton book. We have seen the concave convex rule. Okay. So when there is a convex surface move, okay, the gliding takes place on when the convex move over the concave, the gliding is taking place opposite the direction of the osteokinematic movements. When the convex move over concave, concave over convex, so both the gliding and the osteokinematic in the same direction. This is what concave convex rule. It is told by the Colton bone. What is the other Colton bone hypothesis? The attachment of the capsule on the concave is closer to the joint line, while the attachment on convex is far away from the joint line. So when the capsule is attached on the concave area, that should be very closer to the joint line. So the concave part of the joint, it has a convex surface of the joint, concave surface. So there's a concave area, also this joint capsules will be attached, and convex surface also the capsule is attached. So the concave surface area where the capsule attached, that's definitely closer to the joint line. The joint line, when you see that, from that the attachment side is very, very closer. But in the convex area, the attachment of the capsule is definitely far away from the joint line. This was first the hypothesis of that. Next one is the width of the convex surface is bigger than the width of concave surface of the joint. Any concave convex joint, if you say, you have to see that the width, the diameter of the convex surface, definitely that is bigger than the width of concave surface. Yeah. Now we'll see the Concave treatment plan. So what is the treatment plan here? So let's define the directions of the tractions and glides. So the tractions and the glides, that will be combined by the Colton bones. other authors has been not told about the tractions of the glide. So they're told about the glide. That's it. Colton Bone told you apply the tractions, along with the traction, give the glides. This is what Colton Bone told. The plane is situated on the concave surface, and that remains with the concave joint surface, whether the moving joint partner is concave or convex. So you can see the picture diagram. You can see that there is a concave surface and convex surface. The convex surface is apply the tractions. Okay, then there's a traction applied. Along with the traction, there's a glide. There's a glide from up. There's a vertical line. So this is where glide is applied. So when the glide is applied, there is a gliding. The movements is taking place between the concave and convex. There is a traction applied. The capsules around the joint will get stretched. So this is what the main the treatment plan of the Colton Bone. So what are the Colton Bone grades of capsule stretch? Colton Bone also described the grades, but these are entirely different from the Maitland grades. You can see this pictures, grade 1, grade 2 and grade 3. So the grade 1 will be given when there is a slag, there is a soft tissue surrounding the joint is in the loosening stage. When the soft tissue surrounding the joint, okay, any joint, I mean any soft tissue, tools, things under the capsule. So it should be in the loosening position. In the loosening state, when you apply the mobilization, you can apply the mobilization that is on the grade 1. And same mobilization we are doing, but now the position is not in the loosening state. You are keeping it on the little tighter state. So it is not in the resting state. Say for example, the shoulder joint you take, first you are giving the capsule in the loosened state. Next one almost 90 degree to 100 degree, you keep the shoulder joint in that position. Definitely the capsule in a little stretch. It is in the tighten position. Now we can apply the glide. Third is grade 3 is a complete stretch. Now the capsule is not in the tighten. It is full stretch, taut completely. So full complete stretch position. Now we have to apply that mobilization. But here it should be the very careful. The grade 3 mobilization. The grade 3 mobilization when you give, the very easily the soft tissue can able to go for tear. So if you can't give the vigorous mobilization at grade 3. So the position of the joint is completely, it's in the close pack positions. So it is in the close pack position, grade 3. Grade 1 is in the loose pack positions. Completely the capsules, everything is loose. In the loose pack position, you have to give the mobilization. Grade 3 is a complete close pack position, complete taut. The capsules on the joint is taut, and now we are giving a mobilization. Grade 2, it is not loosening or not to stretch. It is in the little tightened state. So in that things we are giving the mobilization. It's called, you can see this. So the low actuality, the situation that requires a mobilization force towards end of grade 2 or at grade 3. So what is the high actuality situation that requires light force at grade 1 or towards the beginning of grade 2? So this is what the kind of capsule stretch the Colton Bone grades of mobilization. We'll see the next one is David Butler. David Butler told a different way. He's not telling about the capsules or articular surface, that everything. He said about peripheral nerve. So the peripheral nerve which passing over the joint, so the peripheral nerve will become tight, so all capable to for the restriction of the movements. So that any movements, whenever you do the movement, wrist extension you do, definitely the radial, the median nerve will be stretched. Okay, and there is a to and fro movements. Easily the peripheral nerve can able to move to and fro, and the upper limb nerves and lower limb nerves can be stretched. You know that what are upper limb nerves, median nerve, radial nerve, and ulnar nerve. Lower limb nerve, you have sciatic nerves and the femoral nerves. So we'll see about now as a Butler the common techniques. SLR, straight leg raising test. So when the patient is in the supine lying and hold the limb and try to raise the limb. So when it is reached to the 70 degree to 80 degree, the sciatic nerve will get stretch. So So furthermore, that if you want to stretch complete the sciatic nerve, there is a peroneal component. You can do the inversion. Along with the inversion, do that the sciatic nerve and the peroneal component of the nerve will be stretched maximum. Okay, so that the same thing will be repeat several times. Then definitely the sciatic nerves and peroneal component of the nerves will be become loose. SLR, that's what SLR with SLR. Okay, straight leg rising with inversion, and that will stretch the peroneal component. SLR with eversion, that will stretch the tibial component of the nerves. And prone knee bend test. So patient in the prone lying position, and the knee will be flexed passively and stabilize the spine. The pelvis also, knee will be flexed completely. The heel of the foot that will come and touch on the gluteal muscles. So that is a complete knee flexion. So that time the femoral nerve starts stretch. Furthermore, stretch if you want to do, maintain the knee flexion. By maintaining the knee flexion, you stabilize the thigh and the pelvis, and you try to do the hip extension in the same prone line. Do the hip extension. So in the groin region, from origin to complete the course of the femoral nerve will get stretched. This is called the prone knee bend test. Slump test. The patient is sit, so the cervical spine, head, thoracic, everything will be flexed, and now the patient will be try to in the high sitting portion. The patient will try to do the knee extension. So complete full the meninges will stretch, and the peripheral nerve also will be completely stretched. It's called the slump test. And upper limb tension test. Upper limb tension test. This will begin for the stretch of the median nerve and radial nerve and for ulnar nerve. And lower limb tension test is prone knee bend test and SLR. So these are all the things of lower limb tension test. So the treatment and the diagnosis will be the almost similar here. So you do the test whether the nerve has been tensed or not, shortened or not. Yes, if the nerve is been shortened, the movements are not allowed. Okay, again come back to neutral position. Again do the same way stretch. Again neutral it, come back to the neutral position. Again you stretch. So stretch, relax, stretch, relax, stretch, relax, repeat for 10 to 12 times. Then after that, definitely the range of motion will be improved because the peripheral nerve will become loose. So this is what the main, the concept of the David Butler technique concepts. Okay, so here will be the end. Is there any questions? I'm very happy that. And thank you for listening.
Hello, thank you, sir. Thank you, sir. Thank you. Thank you for a wonderful session. Sir, I have a few questions, sir. So regarding
Yes,
the
sir.
common indication and contraindications for joint mobilization, can you list out a few of the indications and contraindications for those, sir?
Yes. If there is a contraindication, definitely there should not be any inflammation or infections. If there is inflammation conditions, absolutely that it contraindicate for the manual therapy. It's a mechanical therapy oriented, so inflammations and infection diseases, the joints will not be accepted. Or unstable joints, if the joint has been dislocated or subluxed, unstable joints, and non-cooperative patients. Sometimes the patient will not understand about that, what you have been giving the treatment. They may think about that you are going to do something fast movement and going to release something, so I may get a tear. So patient will be very conscious and he will not allow that joint to be loose. So those patients also we cannot able to go further. If there is any lock syndromes, like even commonly the facet lock syndromes, if we have to examine the patient, until unless there is no inflammation and infections, mechanical cause, yes, absolutely the manual therapy
Can
is
be indicated for mobilization. Yeah, okay. Okay, sir. Then one more question, sir, regarding the butler mobilization. So what is you have explained regarding the ULTT, that is upper limb tension test. So can you explain for upper limb tension test for the radial nerve and the ulnar nerve?
Yes. because I have not gone for each and every
Yeah.
concepts in detail, so I have not
Okay.
been
Yeah. Yes,
explained
sir.
about that. So I'll tell
Okay.
about what
Okay.
is that the concept for radial now.
Okay.
For radial now, the full course of the now will be stretch. So that's what main David Butler concept. So we have to be understand the nerve originating from where and what is the course of the nerve. The radial nerve comes from the
Okay.
posterior aspect of the scapula, posterolateral aspect of the humerus, and comes to the lateral aspect of the elbow and continues on the lateral border of the forearm and posterolateral aspect of the forearm and come to the wrist lateral aspects. So the full course of the nerve has to be stretched. So what the methods of the mobilization, the stretch here is protractions and the shoulder flexion, adduction with internal rotation, and elbow is in the extended positions, and forearm should be in the pronations, and the wrist should be in the flexion, and finger is in the flexion completely this way. So in this way,
Okay.
so
Okay.
completely stretch.
Okay, sir.
So
Okay.
as the internal rotation we can give. So the patient will get the stretch force on the posterior aspect of the complete the course of the radial nerve. To sensitize the stretch, we can ask this by holding this position. We'll ask the patient to go to the side flexion of the opposite side flexion. Okay, with the right side, we can
Okay.
ask the patient to
Okay.
leave the cervical spine,
Left
side
side.
flexion to the left side. So automatically, definitely the brachial plexus, okay, that also will get stretched. So this will be sensitize the stretch more. For ulnar now, it comes the middlemost aspect of the arm and the elbow regions. And very important here, the ulnar now, it comes just behind the middle epicondyle. So we are supposed to do the elbow flexion. Okay, here ulnar now it's supposed to be elbow flexion. So by doing elbow flexion only, the ulnar now it's get a bend on just behind the middle epicondyle. So as you do the elbow flexions, the bend area will get stretched. So there is a stretch force will be at the bend point, and in that position, elbow flexed position, do the abduction with external rotation, and the wrist supposed to be in the flexion and little bit of radial deviations.
Okay,
So
sir. Thank
complete
you, sir.
ulnar now will get stretch.
Stretched. Okay, sir. Okay. One more question, sir. So, how
Yes.
will you sensitize the slump test? So, while we are going to do a slump test, so this is sitting,
Yes.
then neck flexion, then extension of the knee and the dorsiflexion.
Yes.
So, what is the sense? How will you sensitize that slump
Yes.
test further?
Yes.
Yeah.
It's a good question that. So the patient is in the high sitting position. When the patient is
Okay.
sitting, therapist also should along with the patient. So when the patient is high sitting, therapist also should be high sitting position. Therapist leg should support on the patient leg. Okay.
Okay.
For example,
Okay.
I'm sitting that my right side the patient is sitting. Okay. My right leg should support the patient left leg. So the patient leg is hanging down, so left leg will be support. My right leg, okay, right leg and the foot will be support the patient, left leg and the foot. Now I have to hold the patient head and the cervical spine. So patient should be completely relaxed, and I have to operate the patient's full movement. So
Yeah.
the neck flexion, first the neck flexion and apply the pressure, and the lower cervical flexion, and slowly the patient should bend the spine flexion also, okay, and the lumbar flexion. So in this position, I hold certain range, then slowly I do passively. By my leg, I have to do that extension of the patient left leg. So when I extend the patient left leg, patient say I'm getting the pain on the left side. So the slump test. Furthermore, that we want to sensitize, I can able to increase that knee extension. So that even degree by degree knee extension, if I increase, patient will get more stretch. And
Yes.
if
Yes.
I understand this is the what, even I can feel that resistance also. Patient the resistance, the meningeus stretch resistance, all I can also feel my leg because I'm lifting. The patient is not lifting the knee extension. Okay, it has been done by myself passively by my
By
leg, so
therapist.
I can
Yeah.
feel the resistance. So where I feel the more resistance, there I should stop. I should stop and I
Okay.
have to wait for that. Again, I have to lower the patient leg. Few degree, just a few degree. If I lower the leg, patient say, yes, I am relieved. Okay. Now
Okay.
again, some more flexion. I have to do more flexion of the body. Then again the same range tried to come, previous range when I tried to come by knee extension, but that has been very painful because already then the meninges is stretched. So this what I can repeat for the few more times later on. Now the patient, I'll ask the patient to come back to the straight position. Now the patient is sitting erect position. Now we do the extension, very, very easily the extension will come.
Yeah.
Very easily the extension will come because the stretch, complete
It
the
is
peripheral.
stretched. Yeah, yeah.
Yes,
Okay,
this
sir.
is what.
Thank you so much. Sir, another one question, sir.
Yes,
Regarding the
ma'am.
SLR, can you tell the degrees? So, if it is up to 20 degree, it is of nerve involvement, and if it is of joint involvement, if it is of muscle. So,
Yes, ma'am.
can you
Actually,
explain
the
it a little bit?
SLR, yes,
Yeah.
ma'am. That SLR, this kind of clinical significance has been not told by the concept person. The
Okay.
SLR has been the straight leg. By doing this SLR, we can stretch the sciatic nerve because in the sciatic nerve, you can see the sciatic nerve till the popliteal fossa. After popliteal fossa, we can't find out the sciatic nerve separately. That will be separate, the peroneal nerve and the tibial nerve. Even the thigh region also, peroneal component and tibial component will be together. But the together that called as a name something different, that's called sciatic nerve. So, which comes from the your gluteal regions until the popliteal fossa, the sciatic nerve is there. Afterward, this will be divided. So, common peroneal nerve and you have a sciatic, tibial nerve, it is there. So, what the butler told by doing SLR, raise a limb and where you feel the resistance. So, there is a resistance will be feel. Always the SLR will be the passive process, the method, this method. So, but sometime other people will say that this may be the active method, active process of the SLR, but I don't agree for that. What the concept is being told, passively you do, and the therapist should feel the force, the resistance. Yes, the tension will feel the resistance. If you don't mind about the tension, if the skill, the resistance is not been feel by the therapist hand, so there is not a skill. So we should feel, yes, here the movements are free, here the movements are reducing, it's a taut here. So we should feel that. Where you feel the taut, there you should stop it. No other things. We should not proceed further. No, we have to stop there. Then now in that person, try to sensitizing. You have to go for the inversion. By doing inversion, peroneal nerve will be stretched. The patient will get a severe pain. Then again, we go for eversion and tibial component will get stretched. Later on, the same concept, it has been taken at the clinical aspects by doing SLR. So what is the kind of, the pinch? Because already the sciatic nerve has been compressed on the lumbar spine itself. So the length compromise is already taken place in the sciatic nerve. So when you try to lift the limb, so already the sciatic nerve length has been compromised. So when you try to lift, even 40 degree itself, the nerve stretch will take place. So this is early, the nerve has been stretched. So that has been taken as the clinical findings. But this kind of clinical finding has been not told by the butler. Butler told the stretch the nose. That's what. Same the technique. It has been taken for that. Say for example, we'll do the kind of the butter, the rice butter and the things. So we can put a idli and we can put a dosa. We can put a masala, add masala dosa, onion dosa. So we can create it. No other.
Yes. Okay, fine, sir. Thank you for your explanation. It was a very nice, indeed, a very nice presentation. Thank you for coming, sir. Thank you so much. So I will now hand over the session to Mrs. Asha Shanti to continue the session.
Okay, very good evening to all. I, Asha Shanti, coordinator of this event. On behalf of Sri Abhirami Institution, I take this opportunity to deliver the vote of thanks on this session. So I would like to thank our Honorable Speaker, Dr. G. Balaji sir, Principal, Narkund College of Physiotherapy. Sir has given a wonderful presentation on the topic of joint mobilization techniques. I'm sure that most of our students get benefited on this topic today. So once again, we thank you for being with us, sir. So I would like to express our sincere gratitude to our chairman, Dr. P. Perizwami sir, and our board of directors, Sri Abhirami Group of Institution, for providing a logistic support and towards organizing this event. I would also thank our principal, Dr. Jayabharati ma'am, for her constant encouragement and enthusiastic support to organizing this webinar series too. So I also thank our technical department who have greatly helped us in organizing this event. Finally, I would like to thank our delegates, the students who have participated in this event for their enormous support to making this session to in a grand success. Okay, now we are in end of the session. So with this, I conclude the session, webinar series 2. Okay. Thank you so
Thank you, sir.
much.
Thank you.
Thank you
Thank
so
you.
much.
Thank you,
Thank
ma'am.
you.
Thank you.
Yeah.
Thank you very much.
Thank you.
Okay. Now I request students and delegates to kindly fill up their feedback forms. It will be sent to your respective mail IDs. Thank you.